Welcome to the No Plateau Podcast for stroke and brain injury survivors, their caregivers, and the therapists helping them to break boundaries in their recovery journey. Hosted by Henry Hoffman, occupational and clinical therapist, this podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. And now, here's Henry Hoffman.
Hello, everyone. Welcome to another episode of the No Plateau Podcast. I am your host, Henry Hoffman. I'm excited to be with you today. Very much looking forward to today's show. We are going to dive deep on a controversial tug-of-war type topic surrounding upper limb therapy in the inpatient rehab setting during critical weeks following a stroke. There's two major approaches to early care. One focuses on independence and mobility and get home ASAP and turn that bed over as quickly as possible. More of a payer model where the emphasis is on just independence, whether it takes one arm or two arms or one leg or two legs. Another approach is more of that neuro-restorative approach, which the emphasis on science, which is let's really recover the use of the impaired limb as priority number one. And it is a tug of war if you talk to colleagues, not only in the US, but abroad. So we'll talk about all the things to consider, things to avoid, not so much on theory, but more on science. And to help me discuss all this, I invited two wonderful colleagues from Sheltering Arms who spent a fair amount of time in the inpatient rehab setting. So please welcome occupational therapist Caitlin Wright and physical therapist Amber Walter. Welcome, guys.
Thank you.
Excited today. I actually circled this date on my calendar a couple times. So thank you for joining me. Before we dive in, I want to have you guys start off by expanding a little bit more about your personal and professional backgrounds. Does that sound good?
Yeah, that's great. Thanks, Henry. I really appreciate the opportunity to speak to the audience. We've obviously followed a lot of the tug of war happening through the podcast or LinkedIn and things like that. So super interested to be able to share kind of our take and, a little bit more like we'd like to share sort of what we see happening, with patients every day. I think that's really the important part, right? So Amber Walter, I'm actually a physical therapist and I started my career back in 2007, and I started really wanting to kind of bring research into practice, and that really wasn't very popular at that time. So I started with, some low-hanging fruits, some easy things that I could incorporate, whether it was measurement, and then, started incorporating some technology into our care. Fast forward to now, and that blend of, evidence into practice and, sort of doing research in clinical environments and translating research is, really much more popular. And so I was fortunate enough to have a role now as the clinical science director of Sheltering Arms Institute. So I oversee multiple disciplines, PT, OT, speech, and recreation therapy, and how we best translate the evidence into the everyday care practices. So it's really fun. I have a great team to help me, to support me in doing that. And we do a lot of tracking of, what are the real world outcomes when we incorporate evidence into practice.
Wonderful. Congrats.
Yeah, and
Caitlin?
my name's Caitlin Wright. I am an occupational therapy a therapist by background. I, like Amber said, I'm really excited to kind of be on today. I am board certified in physical rehabilitation through AOTA, and I'm also a certified brain injury specialist. I graduated in 2016 and started my career in kind of a split role. So I did inpatient and outpatient at Sheltering Arms. And at that time, we were doing a little bit of tracking of outcome measures, implementing technology, but that really kind of sped up as we transitioned to Sheltering Arms Institute in 2020. And I was actually able to transition from just a unit occupational therapist into my current role. That's the Occupational Therapy Advisor at SAI. This role, I'm really able to focus on knowledge translation, like Amber was saying. I'm part of the clinical science team and really ensuring that occupational therapists at SAI have the tools and knowledge in order to really implement best practice throughout all of their cases, and are really able to kind of implement the latest research and our kind of understanding of the latest research so that we can get the best outcomes possible for our patients.
Wonderful, wonderful. Well, thank you. You guys are doing a fantastic job, and I appreciate you joining today. And for years, Sheltering Arms is known for cutting edge treatment. I remember going back when we first started SABO in 2001, 2, 3, 4. You guys were just taking off like a rocket ship. So in a minute, we're going to learn more about what you all are doing to drive best possible outcomes for your stroke patients. What I'd like to do first, since some of these listeners are patients, some are therapists, and some are new grads, I just want to spend a few minutes teeing up this conversation because it might be foreign to some. So, in general, we now know that the brain is softwired. So it can change, you can reroute it, you can the signals, you can relearn. Early in recovery, that area following a stroke or a damaged brain, let's say, that penumbra is stunned next to the lesion site. It's stunned. It's not dead. It's injured. It's sick. There's weak signals, but the cells are hungry for feedback. And so far too often, they are not getting enough feedback in the hospital setting. And so that's part of the problem. That's a payer system pushed model problem where patients need to get independent fast by teaching these compensatory workarounds. And when I say compensatory, I'm not talking about hiking your shoulder. What I'm talking about is compensation, meaning one-handed dressing, one-handed ADL strategies, using adaptive strategies for safe mobility and transfers. Those are important things to do, but they shouldn't outweigh the number one goal, which is let's get the arm and leg back as soon as possible through a restorative approach. So every minute we spend doing this is one less minute spent on evidence-based treatment. So it is a mindset shift. Yes, compensation has value. Let me repeat that because I know there's going to be some comments. But when they replace recovery-focused care, we're shortchanging the brain potential. So we are sacrificing long-term outcomes for this short-term fix. And it's not even something we would do naturally. If we could have a magic wand and say, patients get endless amount of time and everything's free, do you really think after 2 weeks the patient can be kicked out of the system and onto the street and go home? No, of course they wouldn't be. So, Dr. Teresa Jones, we all know, Kleiman Jones, the 10 Principles of Neuroplasticity. She's been famous in the labs in University of Texas. She says it best that it's not just disuse that holds the patient back. It's a use of the healthy limb on its own that can actively disrupt progress. So when we overuse the healthy side to help, we're actually killing brain cells. And that's a big deal. So research is super clear. Using the healthy side too much rewires the brain in the wrong direction. So what I want to do before we get started, I want to be the bearer of bad news, which I kind of do a lot of, especially on LinkedIn. I try to balance out my posts, but some of them are contrarian. Some are let's keep everyone accountable. And you can't hide from facts. So I wanted to review just a couple quick studies, and then we can talk about how this is impacting Sheltering Arms and your approach in a second. And I'm sure you guys know some of these studies, but I'm going to go back. We have the Bernhardt study in 2007. They were looking at acute patients that were less than 14 days post-stroke. They were using their affected limb only 38 minutes in a 9-hour day. I mean, it just gets worse. Lang and Kimberly had studies back in 2010. The average reps in a subacute rehab setting ranged from 23 to 32 repetitions. Think about that, 23 to 32 repetitions in a session, okay? Hayward and Brower in 2015, another subacute study. This is just mind-blowing. They averaged 4 minutes of active arm movement in a session during therapy, 4 minutes. Serrata in 2016, 7.9 minutes per day was used on the devoted to upper limb therapy, 7.9 minutes. And Newton did a large systematic review ranging from studies starting as early as 2015 to 2023, all on dosing. And what they found was the average reps per session from all those studies was anywhere from 36 to 57. So if it was severely impaired, it was as low as 8 minutes per day for active practice. And what's also crazy, finally, Disability Rehab 2020 McLaren study is out of New Zealand. It was an observational study. They actually observed patients for 1 minute every 10 minutes. They observed them for 1 minute every 10 minutes from 7 a.m. to 7 p.m. And the affected arm moved whopping total of 7.5% of the time in a 12-hour period. So talk about brutal, right, guys? Talk about brutal. So that's what the research shows. It shows that no one's following the stroke guidelines, and we'll get into that in a little bit. No one's doing what the evidence wants us to do, which is that high intensity, high dose training. And then we're shocked and disappointed that we're not seeing the proper results. We're definitely seeing them independent, one-handed as they go out the door, walking safely with a limp. But we're not seeing the recovery that we need to see in that critical window, and that's the problem. So what do we do to change it? Stop wasting most of the plastic window of recovery, those first 3 months, and instead bombard the brain with the right stimulation. And we start off by following the stroke guidelines. You have the UK, Ireland guidelines, you have whatever ones you want. Canada's best practice guidelines, the European ESO, maybe the Australian, New Zealand guidelines. They all say the same thing. Priority number one is restorative. And if they think that the patient has no movement or too many comorbidities, then you scale down to compensatory. And so instead of delivering 30 reps, let's deliver hundreds, okay? Let's reject the idea that rehab has a finish line. So let's emphasize neuro-restorative. That's my goal. That's your goal. That's what we want to preach as a top-line priority. So I've been preaching that for years on LinkedIn. Of course, you get a lot of, why I called it a tug of war, is because you're going to get a lot of people saying, no, we need to do ADLs, they need to be safe, they need to go home safe. Remember, guys, the critical window is on neuroplasticity, not on when you learn how to put a shirt on or eat or groom. You can learn that 4 months later, 3 months later, 2 months later. Now, obviously, we're not going to let you go home in an unsafe environment, but it doesn't take that many minutes to do those things. So that's why I'm excited to hear about what the heck's going on at Sheltering Arms, because I have a feeling you guys are on the right path. The path that a lot of folks are not taking at this point. I've interviewed a lot of hospitals, talked to a lot of therapists, and it's a wide variety of ratios between what percentage of the patients being seen are doing the neuro-restorative approach, and what percentage are doing the compensatory approach. And how does that, what does that look like? So we know there's no debate that we have this issue. There is a dichotomy, it's real, and we need to solve it. And I think by having this podcast and doing more of these types of proactive discussions will help kind of hopefully move the needle, if not 10 minutes or 10%, maybe 3%. So let's start with you explaining a little bit about Sheltering Arms and the services offered, and what the current approach is when treating stroke patients. Particularly, how does it differ from the traditional model where generally emphasis is placed more on compensatory? So whoever wants to take a stab at that one first would be great.
Yeah. I'll definitely talk a little bit about Sheltering Arms and let Caitlin answer more to, how we're treating the upper limb for people with stroke. I mean, you're exactly right, Henry. A lot of times too, when I've taught about neuroplasticity too, I remind people that the brain after a stroke is actually set up to be utilizing that unaffected limb or that less affected limb, like more naturally. Like they don't need to be taught that. It is already actually set up in the brain to do that. The action, potential thresholds are lower. That environment is always there, and you probably could leave them in a room by themselves and they probably figure it out. Like, don't really need the therapist to help them do that. So is a really, really good point. So Sheltering Arms Institute, we actually as an institute are newer, started in 2020, but that is a joint partnership between the Legacy Corporation, Sheltering Arms, which was founded as a free rehab hospital in 1889, and then VCU Health, which is an academic medical center in Richmond, Virginia. So really exciting. I think one of the things that we're going to talk about is just changing inertia. We talk about that all the time at the Institute. There's just an inertia of practice, and you have to have a way to change that. Building the Institute really was a unique opportunity for us. We had stakeholders, whether it was therapists, administrators, community members, former patients, really all come together and say, like, what's needed in a state-of-the-art hospital. And so you're going to hear, a lot of these things were sort of born at the start of the Institute, which I would say made it a little easier, but we spent a good 15 years, like while I was practicing in the hospital, kind of figuring that out and what was needed. So currently we have 114 beds. We're actually in the process now of adding 30 more beds on our 4th floor. So super excited about our expansion. We typically see people in the inpatient rehab hospital with neurologic or major medical diagnoses. So traumatic brain injury, spinal cord injury, stroke, and then quite a number of people, with cardiopulmonary disorders, people with oncologic diagnoses as well. So we're treating a wide variety of diagnoses. We also have 8 outpatient clinics in the region. That continuum of care, huge, really, part of what we do is being able to offer this same care and recovery approach, even when someone, leaves that average kind of 2 weeks, length of stay from the hospital. So we have those clinics, but in our outpatient centers, we also treat a really wide variety of musculoskeletal diagnoses as well. And we do, as a part of our legacy corporation, Sheltering Arms, we offer fitness services as well. So again, just really been important to us over time to maintain enough of that rehab continuum of care to support people through their rehab. And I'll let Caitlin take the hard question about what are we doing for people with stroke.
Yeah. So really at SAI, we are very focused, of course, as you had said, on kind of the rehab, like restorative approach. We're really focused on that compared to, a lot of hospitals or clinics where they're really more so focused on the compensatory approach. And this all kind of stems from all that we've been talking about so far, really, especially like the first thing that comes to mind is those neuroplastic principles, right? So, there's the principle of interference, which is the first thing that I think of when thinking of this like rehab versus compensatory approach, where, that's talking about the phenomenon where learning or adaptation in one area of the brain can actually hinder and interfere with learning something else or adaptation in another portion of the brain. So in actuality, learning these hemi techniques too early, or these compensatory strategies too early, actually interferes with their recovery of their weaker or affected upper extremity. So by teaching these hemming techniques early on, it's actually, making it harder for their recovery, not to mention, these golden 3 months that we're talking about. If we're focusing on the wrong thing, that's just going to make it harder down the road to get some really good functional movement in their arm. So really, after initial evaluation in the inpatient setting and kind of, checking all those regulatory boxes that we have to, we're very much focused on intensity and neuro-reeducation to get as much movement back in their arm as possible.
Good. Well, I want to definitely dive a little bit deeper and understand, go through the motion of a new patient coming in and how you guys decide what the framework looks like and who's getting what and why. But before we do that, we were talking about compensatory training and hemi techniques. That is still the default in many hospitals. So how did your team begin to shift away from that mindset? At what point did you guys shift away from the mindset of, okay, everyone needs to get, ADLs in the morning, everyone do a session in the morning, teach Mrs. Jones how to put her shirt on one-handed, teach Mr. Jones how to, dress, groom, bathe, and doing that normal traditional model that seems so archaic, which is still in a lot of the hospitals. When did that shift change, and what resistance did you face internally or externally?
Yeah, I'll speak to that too, because I think I was, really a treating physical therapist and later became neurologic board certified. And at the time, we were starting the Caitlin Jones work was out. And we were starting to learn more about neuroplasticity, and then really sort of seeing how therapists were talking about how they did any of that, right? So you had sort of the basic animal models, and then the Caitlin Jones articles are trying to help, deliver that sort of practical piece in rehabilitation. And so I think, we were seeing this science, and like I said, I got interested in sort of bringing research into practice. And so it's just sort of like undeniable, like to think like there was a different way to do this. And, certainly for me, a lot of what I was focused on at that time personally was walking. But we shared this as a team, that it wasn't just about legs, clearly. And, just think about, Teresa Jones, it's all about like speech therapy, right, too. So, we're not just talking about, movement. So yeah, I mean, we started to say there must be a different way to do this, and we started making some small changes. I will say, implementing outcome measurement was sort of a pivotal piece for us. Seems unrelated, but shifting away from just what was required on a regulatory standpoint to something that was published more in evidence, like, hey, like do some functional outcome measures and see what that looks like in your practice. It actually was a little bit of a way to dip a toe in evidence-based practice for us. And I think that was really a critical start for a lot of what we did. As we started to make some changes, adopting some technology, of course, Sabo was influential in that. We just started to see that the therapy looked different and the people were responding differently to receiving that type of therapy. It just really felt like we had shifted away to like, what is my therapist doing to me? More towards like, what am I doing in therapy? I personally, when we talk about upper limb, I started to notice that we were no longer having people do sort of cognitive and searching tasks, like searching with their unaffected arm, doing the word search while someone was like stretching or passively moving their affected limb. Like they're literally not even watching what was happening, right? It's just like there's an appendage that someone's, moving to this just really more active incorporation, people standing while they were working on upper limb techniques. So I think people got, the sense to me was that therapists actually got reinvigorated kind of by like, what were they meant to do there with people? And it just felt like there was like a lot more energy around. And then because we had started measurement, we could actually see differences too. It is hard to describe this journey without mentioning technology. So I know that's sort of not the purpose of the podcast, but I do want to be transparent with people that was all happening during this period too, as we were implementing technology. And that's a lot of what we were measuring. I think what you saw, though, is the technology was a response to the science. It was just saying, like, we need a tool to deliver more repetitions. We need a tool to make this more difficult for people, to help incorporate some salient tasks when a therapist only, has two hands.
Right.
So that was the big piece of why the technology was there. And I think it's really just taken off since then. We've just attracted people that really want to work from that approach.
Right. No, it's awesome. And if we take a step back and you think about it, I think the big movement was when constraint-induced movement therapy really took off. Prior to that, it was all NDT, low bath, right? Or other theoretical concepts. People were spending $3,000, $4,000, $5,000 on courses and putting on their resumes that they're NDT trained. Suddenly, CIMT comes out of nowhere, thanks to Dr. Tubb. Learn on use gets defined. Research comes out saying we must do purposeful driven task practice. Kleiman Jones comes out with the neuroplasticity articles. This is on the heels of Dr. Merzenich in the 80s with the groundbreaking studies that show that the brain's soft-wired.
Yeah.
All these things started to come in motion where, guess what? The leading actors in stroke recovery are task training and constraint-induced movement therapy. Those are the leading actors. That's what you should be doing, purposeful, meaningful, intensive. Of course, you brought up the technology. That's going to be more, I call it the supporting cast, whether it's bilateral arm training, robotics, eSTIM, mirror box therapy, mental practice, vibration therapy, all those other great things that we do, BCI. Those are going to be nice adjuncts to the Mac Daddy clinical gangster, evidence, which is going to be constraint-induced movement therapy and task practice. So all that kind of led up to that. And then when we realize, when you look at the rodent models and the human models, that, man, we need to be doing 300, 400, 500, 600 reps to make an impact cortically. And then we started tracking, I just cited all those studies, tracking that we're only doing 20, 30, 40 reps, sometimes less? Yeah. And then the stroke guidelines come out and say, guys, 3 hours minimum, restorative priority, compensatory secondary. But then when you talk to most hospitals, a lot of them are not following it. So that's the story, the end. So, but we're not going to make it the end, right? And so obviously our goal now as clinicians and goals like leaders in this, the rehab space, like Sheltering Arms, is how can we continue to move the needle, do what research wants us to do, still get those patients safely discharged. And that's what I wanted to talk to you about next. But obviously, at some point you said, okay, no more Hemi techniques as a priority. Walk me through, patient gets admitted. What does that clinical criteria framework look like? In my mind, the way I've been talking about it is of course, if you have zero movement, a lot of comorbidities, severely cognitively impaired, no family support, yeah, we're not going to be focused on 500 reps. That's not the model for this person. The model for this person is a, compensation, independent, safe transition. And then if this person continues to improve, of course, we're going to dabble in neuro-restorative, but they might not be the perfect candidate. So who is the perfect candidate? What does that person look like? And what is that? What does week 1, week 2 look like for those patients at Sheltering Arms?
Yeah. So it's funny that you say that. My gut reaction to like who the ideal candidate for restorative therapy is always like everyone. Like, what are you talking about? Everyone is. Or
you're giving up on the person, basically. But you're absolutely right.
Yeah. I mean, I think that is where we should always start. Always, always, always start. So yeah, like you said, we evaluate the patient. From there, a lot of times, in inpatient rehab, we've got a lot going on the first day. You have to kind of check all their ADLs and check all those regulatory boxes. Very soon after that, like Amber was saying, we implemented outcome measures that we complete on eval and then at discharge. And we've also started some intermittent measurement as well with the Fugelmeyer. So we complete, if we're talking about stroke patients specifically, we're doing multiple stroke-specific outcome measures to look at kind of where their function is this specific point in their recovery. And then based off of that, we're looking at guidelines that have been created and so on. But we'll kind of get to that, I'm sure, a little bit later. Back to kind of the ideal candidate, right? So I think we see 2 different types of patients on the inpatient side. We see this patient who has had a recent stroke, right? They're in this critical window where the brain is undergoing all of this reorganization and synaptic remodeling, and their brain is like begging for a restorative approach. Like they just like that arm wants to get better, and like we are here to give them that. And then you have, the other side where maybe somebody who has had a previous stroke has learned some compensatory strategies. Maybe they come in for an additional stroke or something unrelated. That patient is still appropriate for restorative therapy. I think anecdotally, we've seen really good changes in overall outcomes with those patients, especially on the Fugelmeyer. And, even small changes can make functional gains. And we want to make sure that we're giving our patients as much as they can possibly get back. We have to remember that, we all know this, right? This is why we're here. But the benefits of restorative therapy don't necessarily just go away. It can still really impact somebody's quality of life and daily life, depending on if they have really, this group of people, if they really adopted those compensatory strategies, thinking of that interference, right, in neuroplasticity, we do have to think that it may be difficult for them to implement those functional gains with their, weaker or affected arm kind of into their day-to-day life, because it's not going to be kind of habit yet. Amber and I were actually just having a conversation the other day about a stroke survivor that she knows really well. And she shared that if she were to get some more movement back in her affected arm, that she would really want to choose the activities that she would want to do. And, they probably wouldn't be dressing and bathing and all of these ADLs that immediately go in our mind as occupational therapists, because she has gotten really efficient and effective with those compensatory strategies over the years. And it would probably actually take her longer to complete those activities if she was trying to do them bilaterally. So she was, this really kind of changed my perspective in some ways. And I'll probably approach this population of patients differently from now on, because she was saying, like, I don't want to use my arm for those tasks. I want to use, my new function, if I were to get it, on the things that I have difficulty doing right now with just one arm. Or things that I could be more efficient with or more effective with by using both arms. So this is just, I've been thinking about this a lot since we had the conversation, because I think I'm going to ask this group of patients that are a little farther out from their stroke, we're already asking their goals, but really specifically, if they had more function in their arm, like, what would they want to do with it?
Right.
Like, what is their main goal with that function? Because it could be totally different than what is in my mind as an occupational therapist.
Right. No, I think that's a really good point. If the patient gets admitted, there's in my mind, there's a couple different, let's call them avatars. One example of a patient would be mild to moderately impaired, which has movement in the affected limb.
Mm-hmm.
Clearly, we're going to be focusing on task practice and ADLs with the impaired limb. Everyone agrees with that. And that's exactly what the brain wants, especially if it's their dominant side. If it's not, it's going to be more of however you would use your arm prior on your non-dominant side. That's going to be engaged into the activities. That's wonderful. What do you do with the patients who have zero movement and their impaired side? What does the ADL schedule look like at Sheltering Arms for week 1, week 2? Walk me through, because the mild to moderate ones are the easy ones. Mm-hmm. Therapists will do task training, hopefully, meaningful, purposeful tasks with the impaired side, challenging the impaired side, along with all the different technologies that hospitals have, including what you guys have. What do you do with the severely impaired limb at Sheltering Arms that doesn't really have the movement? How does the ADLs work? How does the therapy work? How many minutes of therapy do they get per day?
Yeah. So we prioritize the 3 hours of individualized therapy per day. So depending on what the split up of that is per day for that specific patient, the patient could be getting 90 minutes to 60 minutes of OT a day. We always aim for that 90 minutes. But depending on if the patient kind of withstand that amount, if they have speech in addition, is kind of up to the team to see if they're able to if they have the endurance to do so. A lot of our lower level patients may not have that quite yet. So after the initial evaluation, like I said, we lean heavily into that recovery of the limb. So we follow standardized protocols and workflows that we've created to actually set our patients up on appropriate technologies within a specific time frame. So, those lower level patients, we're going to get them set up on the FES cycle ASAP. We're going to go ahead and get them go ahead and consult any of our specialists that we see fit. So for instance, we have an upper extremity recovery specialist that is able to complete extra practice with our patients who are appropriate. So we're kind of putting in all of those consultations. We have a decision-making aid that from our outcome measures places them into, like you said, that mild, moderate, severe category. For those more severe patients, it's going to tell us what technology is appropriate for the patient, and then also give a frequency of how often that therapist should try to get that patient up kind of into that technology as much as possible, whether that is the FES cycle, whether that is the Armeo power, so fully robotic, getting lots of repetitions without, fatiguing the therapist. So I think that's where a lot of these really low repetitions that we see in research come from, is if I, as the therapist, am having to move and somebody's arm that they don't have any movement or very little movement, I am going to get tired.
Right.
Your recovery should never be dependent on my endurance, right? So that's where, like Amber mentioned, all of our technology, that's really where our technology comes in. And we have really wonderful decision-making aids that kind of guide therapists in the directions of what is appropriate for that patient, and when,
Sure.
and as that patient continues to progress, we're able to also progress those technologies.
Sure. So,
I would love
go ahead, Amber.
I would love to mention sort of three things that are really critical to us for that patient with severe impairment. So the use of support staff is one. The use of hard activities being two, and, sort of that extra practice model. So, we utilize our support staff. So once a therapist sets someone up on an FES bike, they can do that as extra. And, it's not counting towards sort of that skilled therapy for the day. We don't see that as skilled at that point. They're riding a bike. I think there's the sensory component as well. I actually forgot to mention that in my list. So the things that we're doing with robotics or FES cycling or even sublux stimulation, we're continuing to provide this, afferent information to the brain, which I think is critical in these patients. And if you're just focusing on compensatory movement because they don't have movement yet to use, like I think you're really missing that opportunity. And again, use it or lose it, right? And then I think the other piece is trying to focus on tasks that still make them work hard. That is what is going to release, those neuroplastic and neurotrophic factors. So you have to figure out a way, even if it's, not active movement of the arm, that you can work them hard. Otherwise, how do they even have a chance, right? If we're not sending the right chemicals up to the brain to help it rewire, what really are we've said we have no hope for you, and that really was the hardwired model, right?
Yeah.
So I think even for those patients that have those, severe deficits, I think we have to promote that. And our locomotor specialist kind of affectionately calls that planting the seed. And I think for us, again, like it's just too early sometimes, even when those people have zero movement, to say. It's a little bit too early to say. And we're very well aware of the FMA subgroups and things like that, but we're still in such an early period that it's just really hard not to deliver, some standard protocols to really make sure you've done everything right. I think that's really what we're doing.
You brought up a couple of good reminders. I mean, there is a phrase I use a lot is start planting and stop pruning when it comes to synapses. Plant those synapses, stop the pruning, because pruning happens from learned non-use. I think the motivation is right. I mean, there's a window of spontaneous recovery that's weeks. And so if you're telling someone 2 weeks in that has no movement, I'm automatically going to compensatory model with you. You've already just slammed the door on any chance of recovery, when you don't even know if spontaneous recovery may actually give them the extra boost that they need, since they're at a heightened state to begin with, to put neuroplasticity on turbo drive at this point. So if you can bombard their brain with stimulation, even when they have no movement, good things can happen instead of giving up on them. So you guys bring up a really good point. Drill down one specific thing for me. ADL, the hospitals literally still want to spend those morning sessions doing dressing, bathing, grooming. With that severe patient, I know there's case by case, but in general, do you actually see them for ADLs Monday through Friday?
No.
And if you do, is it 1 time a week? 2 times a week? How do they learn? And how do they learn to get? They clearly need to learn to get dressed, groom, and bathe.
Of
When do
course.
you fit all that in?
Yeah. So we still see them once a week for an ADL, and that is really just kind of a check-in to see how things are going. Regulatory, right? So it's kind of their progress note day. I will say we really try hard to time that ADL session with other extra therapy during that day. So they're still getting their reps in, right? They're still getting that intensive neuro recovery of that arm, that extra practice, whatever it may be that day. So that could be some extra practice, like I said, or like Amber said, with FES cycling. It could be some exercises that the therapist gave for them to do in their room by themselves or with a family member. It could be in a group. It could be with our upper extremity recovery specialist. That's all to make sure that they're still using their arm that day and it's not dependent on the actual occupational therapist doing that work with the patient.
Okay. And do you happen to have, because I'm all over minimizing the amount, and I love the once a week with the check-in. And obviously the therapist can modify and say, ooh, Bill still needs to be able to do this. And of course, PT is going to be working on independently transferring as well as OTs, but safe mobility, and then making sure they check those boxes to go home. Where if you go back 30 years, Amber, what would have that treatment look like if it was 30 years prior at Sheltering Arms or anywhere? What do you think would have been different?
Yeah. I think 30 years ago, that emphasis was on like, how do we not get spasticity to develop, right? Like, how do we stretch them to, tears?
Yeah.
Like how do we find just the right splint, that like they're not going to have pain. I think that was a bit of the focus. Certainly the function was a focus. What devices, what, setup are you going to need to still be able to function at home? But I think, 30 years ago is just about 10 beyond before my career. And yeah, it was, definitely focused on ADLs, but also this, definitely an idea of like, don't let the spasticity happen. Like stretching's the answer. I think,
Yeah. And really work on that trunk.
Yeah.
So, and special hands took over 45-minute session. In-room treatment. So I've been preaching, we have this window of time. You guys have said it too. What are they doing in their room? And what can we do to leverage that extra minutes? My attitude is I call it the big three, mental practice, mirror box, and electrical stimulation, whether it's NMES. There's a lot of great articles on just passive stim and what that does for the brain, as well as movement, or FES. It just depends on the level of compliance with the patient and family support and cognitive demand. But clearly mental practice, mirror box, and eStim, in my mind, should be in every, I know we're not there, but I'd love to see a day where we just did it with our friends at Freighter on a different podcast. We talked about electrical stimulation for subluxation treatment. And so many guidelines now exist and many hospitals are now offering a subluxation program. And believe it or not, prior to last year, there wasn't really a formal subluxation program that was well known. And now 24, 36 hours post-admission, everyone's getting eStim on their shoulder, and there's a guideline for that, right? And there's a program for that while they're in their room. Well, the next hurdle, in my opinion, is making sure everyone's doing the big three, adding eStim for other parts of the body, doing mental practice in mirror box. Are you guys at that stage where you're now implementing that? Or is that something you're thinking about doing? Or what are you currently doing in the room as well? I know you're giving them a lot of minutes in group and specialists. Are they doing stuff in the room as well?
Yeah, I think this is a big area of opportunity for us. Some of that's been our, discussions with you, Henry. So we do have a sublux stimulation program that is after pretty careful and thorough kind of procedure to make sure that's going to be safe, then we have support staff that is doing sort of the check-ins. And, our nurses are a big part of that program as well, making sure, that they know what's happening, able to turn boxes on, off as needed. So we do that. We started that almost pretty close to after open. So, I've been so privileged to have just wonderful occupational therapist leaders, kind of helping carry on this vision of, how do we reinvent rehab? And so they've done a wonderful job with that. And I think one thing I wanted to mention about that is we early on tried to use pain as sort of the outcome to track as like a beneficial result. And what we found is people actually then never had any pain. So we thought we were going to see, like, over the course of the application of this stimulation, their pain would drop. But what we saw is people were actually at baseline 0 and at end 0. So it looked like there was no change. But we were actually just really preventing pain. So that was an excellent outcome, and that remains a program today. I think the extra things in the room continue to be a huge opportunity for us. We have all single rooms and very large rooms, and so I would, patients do spend a really good amount of time out of the room. They also have a lot of extra activities, therapeutic rec coming in, sometimes providing some leisure activities for them to do on their own. But I think that more rigorous approach, particularly with mental practice, I think we really haven't implemented that as like a full standard. I am sure some of this is happening, kind of with the right candidates and some of our excellent therapists, but I think we haven't done that in a standard way. We have started looking at some of the more portable tools, soft robotics and things that are available, and leaving those in rooms. But I think we definitely still have some opportunities. Yes.
Well, Caitlin, one of the things I want to definitely continue to work with you and Amber on is exactly that. I am working with other facilities on this same project, and it'd be great to do a feasibility study or see what your hospital thinks about implementing the big 3 plus ADL videos. Mm-hmm. So I think we can also trim some of the minutes by having, I'm working with a software company to literally you take out your phone, scan the QR code, and it's going to walk you through Mirrorbox Mental Practice, eStim, and click on your ADL videos for which level you're at, and you just watch them yourself. If you can fix an engine and build a house on YouTube, you can certainly get dressed by watching a video. You don't need a 5-year master OT ADL guru degree to work with you. So not to degrade my profession, it's just not needed. What say you, Caitlin?
I totally agree. Just adding to kind of what Amber was saying, we do kind of have like a standard practice for the sublux stimulation protocol, and we also utilize the GRASP protocol in room for a lot of patients, and that is very standardized so that if they receive this score on the Fuglemeyer, they will receive this. We're trying to kind of standardize those practices a little bit more. One thing that we have done over the past 3 years actually on our neuro unit is that we do audits. And I think a lot of audits tend to be regulatory. Ours are not regulatory. They're based off of, are you following the stroke clinical practice guidelines? And so one of the questions actually on the audit is, did this therapist give the patient activities to do within their room? So it kind of keeps it open-ended so that it's not necessarily, they gave them the GRASP for this or that, because every patient's going to be a little bit different and be able to do something different within their room. But that has kind of helped our therapist. We've created an expectation that is what needs to happen. The patient should be doing things in their room outside of having a therapist with them.
Right.
So.
All right. Well, let's switch gears just a little bit, and let's have a second for you guys to brag about maybe one of your all-star case examples. Yep. Therapists are probably thinking at this point, okay, I get it. I agree. Follow the science. There are ways to do this. Clearly, if Sheltering Arms can do it, we can figure out a way to do it. some might still be skeptical that they think that by heavy focus on stimulating the impaired side and a little bit of a de-emphasis on functional independence may lead to maybe not the best discharge levels that they're looking for reimbursement or safety. Can you walk me through an example of one of your patients where they came in, did XYZ and left with XYZ?
Yes, I would love to. So initially when I was thinking of good patients to talk about, this gentleman like immediately came in my mind. I worked with him a few times. It was such an enjoyable experience. Just some background on him. So he is 52 years old. He had a right basal ganglia stroke, left hemiparesis. Some personal details about him. He owned his own business. So that was like everything to him. And he loved his family so much, constantly calling his daughter. Just a really sweet family to work with. Initially, his ADL scoring on eval, he was needing up to moderate assist for eating and oral hygiene, so up to 50% help needed for that. And for all other ADLs and functional transfers, he was completely dependent. Had a really severe left lateral lean. He was given a tilt and space wheelchair to use while he was initially with us because he was not able to move in any coordinated manner, and really had lack of movement, of course, on the left side. So we were needing to really protect his skin and decrease any risk of pressure injuries. He, on his initial outcome measures, he got a 4 out of 66 on his Fugelmeyer. So really just reflexes, 0 pounds grip. He actually was able to circle 25 bells on Bell's cancellation. We utilized that to look at inattention, of course, but he had 10 omissions on the left side. So clearly a visual field cut, some pretty severe inattention on that left side, which kind of tracked with everything that we were seeing. And he was unable to do the 9-hole peg and box and blocks test.
So pretty severe.
Yes, this would kind of.
So many people would say
your patient.
Yeah, many people would say pretty much we're going full compensatory mode.
Yes.
Many people. Okay.
Yeah. So reviewing this patient's overall care while he was with us on the inpatient side, he was set up on the FES bike within the first 3 days of admission. That's our expectation and our goal. We audit that as well. And he was set up on our subluxation stimulation protocol within the first week. Initially, because of his deficits, his family was assisting him with that. And then kind of towards the end of his stay with us, he was able to manage it himself. He was referred to our upper extremity recovery specialist and received extra practice about 2 times per week. And that was in addition to any extra FES cycling that he did as well. And his primary therapist timed those extra practice sessions with the upper extremity recovery specialist for the days that she would do her ADL session with him. So again, he was still getting those good repetitions in. He was still getting that intensive therapy. It's funny you were talking about all of the reps, and we always say 400 plus. That's our goal. 400 being what our lowest level patient should get that day. That is our goal for our lowest level patient, and plus for everybody else, as many as you can possibly get. So he was still getting repetitions in those days that his primary therapist was kind of more focused on those, checking in on those transfers and those ADLs. He became part of our sweat club, which we haven't really talked much about, but this is an additional transdisciplinary program that provides intensity targets for our patients. So it's a really good introduction to kind of why we're pushing intensity, why we're pushing recovery, and it motivates our patients incredibly well. if they achieve those targets or those goals within a session, they get a sweatband, they get their picture taken. It's a big deal. And then they're kind of part of our sweat club. So
awesome.
he was part of the sweat club. So he was doing intensive, highly repetitious therapy. He was in the inpatient setting for about 5 weeks, which is longer than our length of stay. I think that was due solely because of his progress. He was making such good gains with us that we were able to extend his stay a little bit. And on discharge, this is what everybody's waiting for.
I'm on pins and needles.
Independent for all ADLs and functional transfers.
Wow, that's awesome.
Really incredible. He went home in a manual wheelchair. So he wasn't necessarily like walking long distances, but was able to transfer himself, complete all ADLs independently. So, I mean, even though we were only addressing those ADLs, 1 time per week, he still gained so much from fully dependent, modish for eating and oral hygiene, all the way up to independent by discharge.
So in other words, even though you did high dose 400 minimum reps, you were still able to get them as independent as needed, and surpass those goals. So it did not, discount or ignore or neglect the functional outcomes. Now, obvious next question. Did we see any improvement at all? Did the limb happen to wake up a little bit?
It did. So his discharge outcomes from an inpatient standpoint, his Fugelmeyer increased from that 4 that we saw before to 25 out of 66. So that's a good
It's really
bump.
good.
I wouldn't say enough to be a huge game changer in his ADLs, but he was able to utilize it a little bit more, right? Grip strength for his left arm was about 1.3 pounds on average. Bell's cancellation, he was able to circle 34 bells with only 1 omission on the left side, compared to 10 at the beginning. So he was paying attention to that left side. He still wasn't able to complete the 9-hole peg in the box and blocks test, though. I will say, so Amber was talking about kind of planting that seed. You were also talking about planting that seed. He went to outpatient with us. He was with our outpatient clinic for 10 weeks, 2 times a week. And I wish we had like a drum roll or something. His discharge outcomes from outpatient, his Fugelmeyer increased to 63 out of 66.
That is awesome. That's amazing. So how many weeks you said? 10 weeks?
10 weeks. So overall, from his initial admission to the end of outpatient, it was 15 weeks. 15
weeks total. So he was at what is that, 4 months?
Yeah.
So, because remember, what I love about that story, Caitlin, and that's amazing. And I know not everyone's going to achieve that success, and it's awesome for him. They have, depending on who you read, the subacute stage, some people call it at that point the chronic stage. What I love about that is it's after the spontaneous recovery stage, typically. And that dives into the only other way you're going to make that gain is through the power of neuroplasticity. And the only way you're going to do that is if they're compliant at home. That sounds like he was probably compliant and hyper-motivated. Have the reps by the therapist doing evidence-based care. Because remember, you can learn, neuroplasticity can be positive or negative. I can literally use it for depression, OCD, PTSD, as well as the positive aspects of neuroplasticity. Learning a new language or learning a new sport or learning, a new state of mind. So that's the beauty of neuroplasticity. Anyone can use it at any time if they actually make it purposeful, intentional, and, obviously the dose needs to be there. So that's fantastic news. Wow, what a story.
Yeah. And I think, a lot of times we talk about these recovery trajectories, right? Now, I don't know how his arm would be doing if, we didn't do kind of restorative, whether we did compensatory or restorative. I don't know what his arm would look like. But we talk about these recovery trajectories. And really, I, as a therapist, and I know Amber and you do as well, we have to think about their life trajectories, right? his life would look so different if we went straight to compensatory. Who knows if he would have been able to get back to his business? Who knows if he would have been able to go home with his family? Like all of those things that really mattered to him, he was able to return to, and, you know, and doing it how he wanted to do it. Right. And so I think that's really kind of what makes the difference in this specific story.
And Amber, you know, some people listening might be, well, compensatory restorative. I mean, there's got to be sometimes there needs to be an in-between, like a hybrid. I think it's not binary. I do think obviously goal number one is restorative.
Yeah.
Absolutely. Goal number one needs to be restorative. But we can't be ignorant to think that there's going to be scenarios where there's going to be a blend. The key is if you're going to go down that trap, which is you got to be careful, it has to be a majority of the time leaning restorative. And then, you know, there's a psychological element. So the counter argument is going to be, well, Henry, you know, if you really want to frustrate your patient immediately and make them become depressed, you know, keep telling them they can't use their healthy limb to do functional things at home. So there's a psychological element. Obviously, when you get home, you're going to have to engage the healthy side. Dr. Jones needs to be closing her ears for this one. Engage the healthy side so you can get shit done. And that everyone gets that. Everyone gets that. But what we're also saying is don't make that the norm and don't make that the majority of the time. So whether you're in a hospital or whether you're in an outpatient center, focus on forced use of the impaired limb. And then when you have to get through life, just make sure it's minimal amount of time. So we're not trying to be binary. It's clearly a blend, but we see the bias towards where we're trying to be. So Amber, closing, I know we have to wrap up, but respect your time, and you guys have been fantastic. Closing thoughts on if we've convinced a therapist in some facility in some part of America that, you know what, these people make sense. Research makes sense. The guidelines make sense. I want to jump on board. What do you recommend they do? You clearly did it with Sheltering Arms. What do they need to do first? And what's that process look like? And what are your closing recommendations?
Yeah, I think one of my strongest recommendations when I talk to people about working towards or clinical practice change is start with some friends. So I think, you know, it's really tempting to think about take that person that's the biggest naysayer and is the person that's all compensation. We have to do the ADLs. We have to get them independent. And if I turn that one person, then it's all going to be okay. And everyone, my experience is that you spend a lot of time and energy and you may get a pretty limited result, right? Where typically you can start is with the people who, you know, are kind of on that edge with you. They're like, hey, I hear you. I get that. Like, I believe that for my patients. I had a patient, maybe, you know, it's like sort of like Caitlin's and, you know, it worked really well. But then I'm also hearing like, we have to get them independent. We have to get them independent, you know, but start with that person that you think is more aligned with the evidence and the science. And you start producing some of these cases that you can share with people. I think the other piece of that is please engage your patients to know what the evidence is. And that's what we're doing with that sweat club idea is really a patient mediated strategy. So really great example. We started that with walking therapy. And we had a patient during their OT session look and say, how do I get one of those? And so the OT turned, you know, to the PT and was like, hey, can you help me get that pulse that heart rate monitor set up? So if you start talking, you know, if you're really on the side of wanting to enhance the recovery model, start talking to the patients about what you're doing because they're going to start talking about it. And that's going to be honestly a lot more exciting than, you know, an in-service or lecture. It's going to be the reason why everyone started doing this awesome. is to hear from the people who need it.
Yeah, it's a push-pull strategy for sure. And forming the alliance, obviously a little politics as well. But I think the combination of all those things might get them over the finish line. Is it okay if in the show notes I leave your contact details in case some of the therapists have follow-up questions regarding any of your fantastic programs you have or I can help too with references. Is that something that you're willing to share?
Yeah, absolutely. Please. And we've just started trying to produce more education and resources too. So I hope, people will kind of follow us and see that grow over time.
Excellent. Caitlin, any closing thoughts on your end?
I don't think so, other than just thank you so much. Amber and I both love talking about this. So if anybody has any questions, please reach out. We would love, we want more people to do this. So please reach out.
Well, I'm going to reach out to talk about the big three with you guys so we can get that started ASAP. Well, thanks so much, guys. I really appreciate the time. Hopefully some of the listeners, whether the patients, new grads, therapists, thought that this was meaningful. And until next time, you guys have a wonderful week.
Thanks, Henry. Thanks for all you do.
I appreciate it. Thanks, guys. Take care.
Thank you for tuning in to the No Plateau Podcast. Please make sure to like and subscribe to stay up to date on more stroke and brain injury recovery stories. The No Plateau Podcast is intended to give you an insight into stroke and brain injury survivors' journeys. Any opinions given on this podcast are strictly the individual's, and we do not suggest that you necessarily hold the same viewpoints as anyone on this podcast. This podcast is intended to supplement stroke and brain injury survivors' recovery journey. Therefore, all content affiliated with this podcast is for informational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health providers with any questions you may have regarding a medical condition. Reliance on any information provided by the No Plateau Podcast is solely at your own risk.